So surgical intervention, if you make the decision that you do need to operate, similar to adults, you can come from an anterior approach or a posterior approach. We've got all the same options that we use in adults: lateral mass screws, pedicle screws, laminar screws, and we throw in posterior winding constructs, which is necessary sometimes for the very young children. With an anterior approach, if you're considering that, typically that's indicated, we do that when you've got disruption or instability or lack of formation of the anterior vertebral column. Typically, we can expose from C2 down to T1 or sometimes T2, depending on the anatomy. We usually use an arthrodesis with an interbody cage. The instrumentation, typically you can get down to about 3 to 4 years of age. But no company makes pediatric size instrumentation. I put this slide in here. This is a table from a recent book chapter. You can see the different companies that have plates here, and we've got the thickness, width, length, and the screw length. And the purpose of putting this up here is to show that, for instance, this plating system may have the narrowest plate, but it's not the shortest screws, and it's not the thinnest plate. And there is no one system that has the smallest features of any plate. So you just got to have an idea of what these numbers are if you're going to try to think about using them in a young child, to make sure it's technically feasible and things will fit. The other things to think about the anterior approach is with young children, you've got a smaller vertebral body radius of curvature, you've got a smaller disc space height, you've got increased thickness of the cartilaginous end plate. So you have to be careful when you go in there if you're doing an anterior approach and you're taking out a disc or something. If you're really aggressive there, you may not have room for the screw at the end because the vertebral body is so small. So you've really got to look at the anatomy carefully, know what type of instrumentation is available, and determine if it's technically feasible to place screws. I've had situations where the length of the vertebral body is from front to back is only 8 millimeters, and the shortest screws you could find are 10 or 11 millimeters, and that's just not going to be a good option for a standard adult instrumentation system. If we flip over and look at the posterior approach, we typically look at this when we've got posterior element disruption. The type of instrumentation, you can use wires and cables. Typically, we use these for very young patients because the bones are just not big enough to accommodate any screws. Both titanium multi-stranded cables as well as Merceline tapes is available. Lateral mass screws are certainly the most common. Probably everyone on this call has placed these before. Typically, we use an entry point slightly inferior and medial to the center of lateral mass, and we've got an upward and outward trajectory in order to avoid the vertebral artery medially and the nerve root inferiorly. Laminar screws are an option, but typically it's mostly just for C2 and C7. It's uncommon to find lamina in children that can really accommodate laminar screws, particularly bilateral laminar screws, and anatomical studies in adults and others have shown this. Pedicle screws are also limited because the size, the young pedicles and so forth. These are important to consider, especially with a little bit older children who have significant deformity. If for children where you've got long constructs and that have failed from proximal junctional kyphosis and you're extending up into the neck, or if you're doing large vertebral column resections, and lateral mass screws aren't going to be able to stabilize the spine and hold that over a complete vertebral resection. These are some pedicle screws are something that can be very, very helpful. Typically, we use arthrodesis with a on-leg graft using your own bone or cadaver bone. And BMP is uncommonly used in children because they fuse really well, but appears safe from the few small studies that have been done. So here's our polling case number 2. This is a 3-year-old girl who had a vertebral formation anomaly, failure of formation of the anterior body there. She developed neck pain, and now she's developing myelopathy. You can see in the film she's got a kyphosis here, a failure of anterior body support, and she's got signal change in the cord there. So my question for the group, is this something that you would recommend observation for or bracing? Surgical stabilization with a only anterior approach or with a only posterior approach, or is this something that you would stabilize with both an anterior and posterior approach, given the limitations of size of instrumentation in a 3-year-old child? So let's give you a moment to fill those out. Okay, so it looks like about 70% would recommend both an anterior and posterior approach, and about 30% would have just done a posterior approach. So my thoughts were in line with the majority. I felt that an anterior approach was important for this because there was a failure. We needed support anteriorly with bone graft, but the type of plating system, it was too small to put any type of conventional adult spine system in there. So the only thing you can use is a type of a mandibular or a hand tray, and the biomechanical stability that provides is completely unknown. So after that, I flipped her over, and she was this girl was old enough to put in some lateral mass screws as well. So probably the single most common question I get asked by people is, how young can you place instrumentation in the pediatric cervical spine? This is a table from a recent publication, and you can see with the type of fixation here, the type of screws, what the youngest reported age of a patient that's reported. And if you look at the age groups, the really young children typically are placing screws in and around C2 because it's the largest, bony structure in the region and the best place for screws. But if you look at the subaxial cervical spine, the age groups are a little bit older, and that's just because the bones are small in lateral mass and the pedicles are smaller. So it's difficult to put, and most of the time you can't put instrumentation, standard adult instrumentation, in the subaxial spine until a little bit older. As mentioned, you can use hand plating systems or a mandibular plating system with the anterior approach. We do this in the young children, but again, the biomechanical stability is completely unknown. The second most common question I get is, what are the effects on growth in the immature spine? If you fuse these kids, what happens over time? Do they still grow? Do they not grow? So we looked at this in the craniovertebral junction, and then we also looked at this with looking specifically at growth after the subaxial spine. We did a multi-center study through the Pediatric Cranial-Cervical Society. We had about 81 patients in 15 centers, and about 2/3 of children after fusion of the subaxial spine continue to grow vertically through and across the construct. There's no clear reason why about 1/3 of the children don't grow across the construct. We weren't able to identify any specific risk factor for that. If you look at kids that did grow, as you might expect, the longer the construct, the less the growth there was. So the red lines here are the expected growth based on normal growth studies. And then the blue is the average slope of the line. So you can see that the slopes of the line for 2 and 3 level constructs are very similar to a normal growth. But when you get into 4 level constructs, you see the slope of the line being less, indicating that the growth vertical growth has been affected by the fusion construct. So in the last minute or two, I'll throw out some clinical pearls for some crazy cases. These are the types of cases where typically you've got underlying genetic syndromes, you've got crazy swan neck or kyphotic deformities, and the first pearl I can say is stall as long as possible. Stalling allows for moderate reduction with bracing. It can stabilize the spine temporarily, and it allows importantly, time for growth. This is a study published out of Texas Scottish Rite where stalling as long as possible was not followed. And this is a study of 15 children, all of whom received instrumentation at less than 3 years of age. 40% of them were less than 1.5 years of age. And this is the type of outcomes, because you can't put the screws in that young. And just with some type of bracing and halo construct, you don't get good reduction, and you get fusion or pseudoarthrosis. And there are major complications in the majority of patients there. So you want to stall as long as possible. Second recommendation is use traction. Kelly mentioned this a little bit, Doug mentioned it too. It is barbaric, but it really works a lot of times. It minimizes the need for anterior approach. And importantly, it permits the assessment of a neurological exam during reduction. It's the safest thing you can do. And we've done this in kids, as early as, in the newborn period. There's a kid in a neonatal ICU, and you can see this horrendous kyphotic deformity and cord compression. And you can see this, pretty beautiful reduction. And this kid's spinal cord's totally up and up now. There was no compression. And this kid's nearly 2 years of age now, just in a cervical collar, and I haven't had to operate on that kid yet. And the options at this age are far, far greater than the options when the kid's, in neonate. The last thing is start posterior. It's when you've got a really young child trying to come from the front to get this type of kyphotic deformity. That is a deep, dark hole with a very long reach. And the instrumentation that you can put in the front in young children, you just don't have the ability to distract and reduce anywhere near as powerfully as you do with a posterior approach. So start posterior, it's a more familiar approach, it's less risk, you have more options. And I would say if you're really dealing with a subaxial spine problem, like in this case, where there's nothing intrinsically wrong at the craniovertebral junction, often we have to go up to the occiput to get a good point of fixation, but consider not laying bone graft down at the craniovertebral junction. That way you can bring them back, a year or two later when this is fused, and you can disconnect the occiput and give them some more motion at the craniovertebral junction. So those are the 3 clinical pearls. That's all I have for you. And remember, the ultimate goal of this is to stabilize the spine so these kids can have as normal lives as possible.